Good afternoon, and welcome to today's IAC webinar, Echo Evaluation of the Right Heart in Pulmonary Hypertension, Updates from the 2025 American Society of Echocardiography Guidelines. My name is Katie Gibson, and I am the Director of Accreditation for the Echocardiography at IAC. Before we begin, I'd like to take a moment to review a few technical matters, and I'll let you know how you can participate in today's session. We'd like today's webinar to be interactive, so we certainly encourage you to submit your questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar as we monitor the questions throughout the presentation, and we'll try to answer as many as possible during the live Q&A period. Also, on the left sidebar is the Resources tab. Click this tab for links to today's handout, which is a copy of the new ASE guideline for the assessment of the right heart and pulmonary hypertension. Lastly, in the lower left of the player, please note the Request Support button. If you're experiencing any technical problems during this webinar, click on this button, and a technical expert will be there to assist you with any issues that you may have. For those of you who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and will also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I'd like to introduce you to today's guest presenters, Dr. Monica Mukherjee and Mr. Kenneth Ridley. Monica is an associate professor of medicine in the Division of Cardiology at Johns Hopkins University with clinical and research specialization in advanced multimodality cardiovascular imaging. Since 2012, she has served in the echocardiography laboratories at both Johns Hopkins Hospital and Bayview Medical Center, where she currently holds the roles of Associate Director of the Echo Program and Medical Director of the Bayview Echocardiography Laboratory. Dr. Mukherjee's research centers on the application of innovative imaging approaches to detect chamber-specific myocardial dysfunction in systemic and autoimmune diseases. Kenneth Ridley has been in the field of echo for more than 22 years. Mr. Ridley is a graduate from the UMBC Cardiac Ultrasound Program and has worked at the Johns Hopkins Bayview Medical Center ever since. He was promoted to lead cardiac sonographer in 2007 and has served in his current role as non-invasive cardiology supervisor since 2014. Mr. Ridley has been a member of the American Society of Echocardiography since 2006 and a fellow of the ASE since 2016. So with that said, I'll now turn this webinar over to our speakers today. Monica, would you like to start us off?
Yes, thank you so much, Katie, for inviting Ken and I to speak today about updates on the American Society of Echocardiography guidelines. I don't have any relevant disclosures, but I do want to thank all of the sonographers who helped inform the guidelines and all of the recommendations that we will be making today. So the objectives of this webinar will be, first, we will review the American Society of Echo guidelines, as well as the current World Symposium of Pulmonary Hypertension classification system. We'll talk about this concept of adaptive versus maladaptive right heart remodeling and what that means clinically. I hope to highlight how important echo is, not only in screening for pulmonary hypertension, but how we can use echometrics for risk stratification and guiding therapeutic decisions. And then we'll also identify some of the echo characteristics that are unique to each of the pulmonary hypertension classification groups. So I'll start with some background. Pulmonary hypertension is currently defined as a mean pulmonary arterial pressure of greater than 20 millimeters of mercury at rest. But for many years, it was actually defined as a mean PA pressure of at least 25. And what happened was that in the 6th World Symposium, which was back in 2018, the task force members suggested that this definition actually be lowered because there was an effort made to emphasize early detection. How can we get to these patients sooner? And there was a wealth of epidemiologic studies that suggested that patients that had mildly elevated pulmonary arterial pressures were at an increased risk for developing overt PH within 5 years. And so this lowered threshold that we saw in 2018 focuses on early detection and was reinforced again at the last meeting in June of 2024. And one of the most common problems in pulmonary hypertension is how do you tell if the pulmonary pressures are elevated because of pulmonary arterial hypertension or pulmonary hypertension because of left-sided heart disease? So the classification of PH is simply based off of whether it occurs pre or post capillary bed. Group 1 is pulmonary arterial hypertension. This is PH that's due for idiopathic reasons, meaning that we're not really sure, hereditable mutations, drugs and toxin induced. In this category, we also see patients with connective tissue diseases like scleroderma, as well as HIV. Group 2 pulmonary hypertension is pulmonary hypertension due to left heart disease, meaning left ventricular systolic and or diastolic dysfunction, significant aortic mitral valve disease, and some of the congenital diseases fall here too. Group 3 pulmonary hypertension is also precapillary. This is pulmonary hypertension due to chronic lung diseases, so COPD, interstitial lung disease, obstructive sleep apnea, obesity, hypoventilation, as well as chronic exposure to high altitudes. So anything that causes chronic hypoxia or chronic lung disease. Group 4 is pulmonary hypertension due to chronic obstruction of the pulmonary vascular bed, so patients with acute PEs. And I've noted the prevalence of each of these classes, and you can see here that group 4 is actually quite low. And that's because after patients come in with an acute PE, we often don't see them again until several years later when they present with PH. So the actual prevalence of what group 4 is probably widely underreported. And then group 5 is pulmonary hypertension with unclear or multifactorial mechanisms. In this category are patients with sarcoid as well as other systemic diseases. Now, when we're diagnosing PH, we're really looking at invasive measures from right heart catheterization, and that is how you actually diagnose PH. And you can see here that the previous definition from the 1970s until 2018 was a mean pulmonary arterial pressure of greater than or equal to 25. And again, in 2018, that definition was lowered. So we look at a mean pulmonary arterial pressure of greater than 20, a normal wedge pressure, or your left ventricular end diastolic pressure, and an elevated pulmonary vascular resistance. And here we see groups 1, 3, 4, and 5. Post-capillary pulmonary hypertension is a mean PA pressure that's elevated, but your wedge pressure is also elevated. If your pulmonary vascular resistance is less than 2, this is probably all isolated post-capillary. But if it's elevated greater than 2, you're thinking that maybe this might be combined pre and post-capillary. So what does this mean clinically? Well, if a patient comes in and we're worried that they may have PH or really any shortness of breath, the first line is echo. And that really led to the first guidelines that were released from the American Society of Echo in 2010. Echo is the most common imaging modality used around the world to screen for pulmonary hypertension. And it really is our mainstay for screening, monitoring of therapeutic response, and also prognosticating. But a lot has happened since 2010, including the lowering of this diagnostic threshold. And that led us to revise the guidelines, which were released in March of this year, really emphasizing how echo can be used not only for screening, but for prognosticating patients with pulmonary hypertension. Now, when we start talking about the RV, it's really a quite complicated anatomic structure. Before 2010, there was really no focus on the right ventricle at all. And in fact, back in the 1600s, some of the first studies about the RV suggested that it was just a passive conduit. But in the last 20 years, the RV is really fully recognized as a key player in outcomes across multiple disease states, whether it's PH, valvular heart disease, congenital heart disease, and even heart failure. The RV is fully recognized as a key contributor and driver of outcomes. Now, why it's so complicated is that the structure of the RV is very trabeculated, it's thin walled, and then it varies in shape based off of loading conditions. And there's no simple geometric model by a single 2D image that can fully assume its ellipsoid shape. And that's why we have to look at the RV from multiple different views. In normal subjects, the RV is this flat, pear-shaped appearance that's folded over the LV, and there are three main parts. There's the inlet portion of the RV, that's the tricuspid valve, the chordae, and the papillary muscles. Then you have the trabeculated apical myocardium, and then the infundibulum or conus, which is that smooth-walled RV outflow tract just beneath the pulmonic valve. Now, importantly, the RV is very thin-walled. There's circumferential myofibers in the subepicardium and longitudinal fibers in the endocardium. So the major vector of contraction that we can see by echo is along a longitudinal plane. Now, what happens to the RV in PH? So the RV functions as an end organ mechanistically. What that means is that as the pulmonary vascular resistance goes up, the RV will begin to hypertrophy to overcome that increase in afterload. Hypertrophy is the initial adaptive response to PH in an effort to increase contractility. There is an increase in tissue thickness and mass by means of sarcomerogenesis, so just an increase in tissue mass. But over time, because there's only that longitudinal myofiber architecture, those contractile increases are insufficient to maintain output. And with sustained increase in pulmonary vascular resistance, that sustained pressure overload causes the chamber to dilate. So there is an increase in the internal radius of the chamber to increase ejection volume through that increase in pressure. So let's break this down. The first point is that RV adaptation, how the RV adapts to increase load, is the main determinant of outcomes. There's something known as coupling. How well is the RV contractility matched to that increase in afterload? What is happening at each chamber level? What are the associated structural and morphologic changes? And as you can imagine, this is a very complex process. It depends on how severe the PH is, how long you've had PH, how fast did it develop, as well as other neurohormonal activation, coronary perfusion, and myocardial metabolism. Now, adaptive right heart remodeling is that first stage. So even though the RV is less muscular than the LV, the RV is able to maintain the same stroke volume with about 25% less of the stroke work because the pulmonary vascular bed is low resistance and highly compliant. So the RV is able to maintain stroke volume with less work than the LV. What happens when the pulmonary vascular resistance goes up is that first change. There's an increase in tissue thickness because there's enhanced muscle contractility. The RV is trying to hypertrophy to increase cardiac output through that increased resistance. In adaptive right heart remodeling, what we see on echo is concentric right ventricular hypertrophy, preserved function, normal filling pressures, and there's minimal dilation of the chambers. And when you look at MRI, usually the tissue is not fibrotic. But then there's this important transition that happens. those contractile increases are insufficient to maintain cardiac output, and the chamber begins to dilate. One of the earliest changes that you will see is this increase in the chamber radius. This mid-ventricular dimension begins to become bigger, and this happens before the base. So here is this kind of transition phase phenotype. The RV end systolic area will enlarge before the diastolic area. And why is this happening? So, the LV can sustain pressures of 200 without dilating. And that's because these are very thin RV walls that are experiencing a high level of wall stress. Now, when I play this image, you can kind of see here this phenomenon known as apical traction. This is a key echo marker that we see marking the transition from adaptive to maladaptive. What is happening is that there's increased wall stress and contractile dysfunction. And the LV is now pulling the apex of the RV leftwards. During this phase, the basal function of the RV is intact. So if you're just looking at the TAPSE or the tissue Doppler S prime, but this is the structure of the RV, you are missing contractile dysfunction. This is a very key sign that we see as the RV is beginning to dilate and become weak. And then the late stage is that now the RV is kind of sphericalized. It's short and fat. So this progressive dilation of the chambers with elevated afterload leads to RV-PA uncoupling. What that means is that the RV is failing against that high afterload. These patients will have congestive right heart failure. If the RV is really failing, and it may compromise LV filling, so there could be diminished cardiac output, and intraventricular mechanical dyssynchrony, meaning that the RV is now so dependent on preload that the LV cardiac output has begun to fall. So again, impaired LV filling, and here we see an example of it with this video. So you can see here in the parasternal short axis view, the LV is very small. There's flattening of the intraventricular septum. The RV is huge and dysfunctional. And then when we move here to the apical four chamber view, the RA is enlarged, the RV is enlarged. There's again paradoxical septal motion, suggestive of intraventricular mechanical dyssynchrony. And look here at how small and underfilled the LV is. Now, what happens along with this process is that there's also distortion of the tricuspid valve and the tricuspid annulus. And there are a few different types of tricuspid regurgitation that we can see. Now, it's important to remember that you can have very severe TR and normal pulmonary pressures. You can have very severe PH and mild TR. So the two things don't necessarily go hand in hand. It's a very complicated process. When we talk about tricuspid regurgitation, there are three main types of TR that we're identifying. Primary TR, there's something wrong with the leaflets. There's a lead that's impinging on it. It's myxomatous. It's displaced like Epstein's anomaly. There's something wrong with the leaflets. There's a primary abnormality. Secondary TR is due to RV remodeling. So just like what we see in functional MR, this is caused by RV dilation and dysfunction. So the annulus is also remodeling. The annulus is getting spread apart and the leaflets are now tethered. The tricuspid annulus is dilated and then the leaflets are not coapting. Any form of PH can lead to functional TR. And again, it's because of remodeling of the right heart chambers. As functional TR develops, it actually will then worsen RV failure because of the increase in volume. So here you can kind of see an example of progressive functional TR. There's also another phenomenon that's called atriofunctional TR. And what that is something that's very distinct. Typically the RV base is mild or moderately dilated, but not severe. And the atria, the right atrium is huge. So these patients typically are older, they have long-standing atrial fibrillation, and it's a slightly different mechanism because the leaflets are not tethered. It's from atrial dilation that's impacting your tricuspid annular performance. And then, of course, you can have a mix of these as well. So what does this mean when we're assessing RVSP? There was a very interesting study that came out in the Journal of the American Society of Echo last year. And what they did was they looked at patients that had severe TR, and they took them to the cath lab, and they also did echo at the same time. And what they found was that if your TR signal was parabolic, the relationship between invasive and non-invasive measures was pretty good. It was pretty tight. But when that Doppler signal became triangular, the relationship fell apart. So most often when we're looking for reliability of RVSP assessment by echo, we should be focusing on the density and the contour of the CW signal. And so again, echo is providing a ton of information of how the RV is adapting to that increase in afterload across varying degrees of pulmonary hypertension. So with that, let's now go into how to evaluate the right heart by echo. And I will go to Ken to start us off with how to obtain the best RV focus view. Ken?
Okay, thank you, Dr. Mukherjee. So in finding the best RV focused view, I usually start in the apical view. We go low and lateral to attain that image. You'll find that if you're low and lateral, your chances of foreshortening the apex are less. And if you don't see it that well there, you start moving up and medial. Also, with RV focused views, you want to, once you get your image in, you either want to zoom in on it, or you either want to decrease your depth and decrease your sector width so you have a clear view of the RV. We go to our measurements from there. I also would advise people, make sure when you're doing your echo, use all views. So you want to, when you start from your peristernal long, you also want to make sure you're looking to see whether the RV is dilated there. This will tell you if you have a dilated RV, you're going to have to move lateral to actually get to where you want to go. So. And right here in this view, if we're looking at this view here, the X view there, the position here is you're too high. You can see with the lungs, if you have a patient with COPD or something, you see how the RV is not that well optimized there. I would move down a space, optimizing the RV, starting with your starting with your gains, your lateral gains. You want to clear that up by moving the lateral gains, decreasing your lateral gain at the top, and then either moving your image down. From peristernal views, I always tell people when I'm training them, start high and medial and work your way low and lateral. That's the best way, because if you do that, you're better off optimizing and actually being able to see where the images actually come in. Sorry. Okay.
Great. And so when we talk about the how to assess the RV from echo, it really should be systematic. And it depends not only on what the sonographer is obtaining, but what we as physicians are interpreting from what you're giving us. And so I encourage the sonographers to do this the same way every single time as well as the readers to do this the same way every time, because we need to look at morphology, function, and hemodynamics, and then take everything together to tell a story in the interpretation. So again, as Ken mentioned, the morphologic assessment of the RV, because of the complex shape of the RV, you have to take several different views, and we shouldn't be using qualitative measures anymore. So the old guidelines said, oh, the RV should be no more than 2/3 the size. That is, you know, really relying on what our eyes can see. And if the transducer is not moved laterally and you're getting a lot of lateral RV free wall dropout, you may completely miss some of those adaptive changes that may precede someone developing severe PH. And so when we look at the apical fluid chamber, again, that RV free wall needs to be in focus throughout the cardiac cycle. From that view, you can get the basal linear, the mid dimension, and the longitudinal dimension. Now, as the RV dilates, and we'll talk about this in a second, these measures also become displaced. So if your apex is over here, this measure is no longer here, right? It needs to be from the true or the displaced apex transecting the tricuspid annulus, and it should be parallel to the interventricular septum and perpendicular to the midpoint or the closure line of your tricuspid valve. You can also look at your subcostal for some of these views, especially in our COPD patients when there's lung interference, to measure for RV wall thickness. The peristernal, you can again see abnormalities in your septal motion. A lot of people, when they're measuring that RV internal dimension, they're transecting the LV instead of the RV. So they're on different planes, right? So this should actually be cutting through the RV. It shouldn't be like this through the LV. From our peristernal short axis views with our aortic valve in the middle, here's your RA, your tricuspid valve, and then your RV is kind of overlaying and going into your RVOT and the pulmonary bifurcation. Again, don't forget your PA dedicated view as well, to look at the distal RVOT and your PA as it bifurcates into your left and right main pulmonary arteries. Now, the right atrium is also extremely important to measure across all populations, but especially patients who are at risk for PH. And the reason why that is that your right atrial size is in the PH guidelines. So it's in the guidelines for recommending therapy. It's in the guidelines for whether or not a scleroderma patient gets a right heart catheterization. And we're not reporting on it. We're not obtaining it and we're not reporting on it. So I can't emphasize enough that from that apical RV focus view, you want to tilt up to see the entire roof of the right atrium and measure it for your studies on all patients, and we should be reporting it. Now, they're traced at the end of ventricular systole, and I've provided area and volume cutoffs. And it's important to also remember that just like the LA, the RA is not a sensitive marker to acute changes in filling pressures. You can also have dilated RAs in patients that have normal filling pressures. It's a better reflection of chronic changes, but it can be appear dilated. So it's always important to index these values as well. And then the last part of morphologic assessment or anatomic assessment is to look at the intraventricular septal morphology. So to obtain this, you're at your peristernal short axis view. And in normal hemodynamic conditions, the LV should be able to maintain a circular contour, so looking like a donut throughout the entire cardiac cycle. When the septum starts to flatten, that means that something's going on in the RV. So if it's flat in systole and diastole, meaning that the LV is unable to maintain that circular contour, it suggests that there's an elevation in RV and pressure and volume overload. If it's just flat at the end of diastole, it might be more of a volume problem. And this is known actually as the eccentricity index. And again, this is in the guidelines for whether or not you escalate therapies in a patient with PH. So it is very important that we are obtaining this and we're reporting on it. And Ken, do you have any tips for how we know that we are at the right plane for assessing eccentricity index?
Yes. So if you look at the first slide there, and you're looking at that septum and how it's positioned up, yeah. So if you're looking at this septum here, you can tell you're too low in this view right here. You're kind of off axis in between a subcostal and in between a parasternal. The one with the check mark by it. Now the person here is mid cavity, and you can see that you can see the fullness of the RV. You can also see the fullness of the LV. This person has moved either up a space, they're in the right position here on the chest on the left side, as opposed to this X one where the person actually has they've slid down. I would recommend that you always view this and go off of what you see with the septum. The septum is going to tell you whether you're too low and you're off axis or not. So that's the easiest way to assess that.
Okay, so now we have a good assessment of all of the RV chambers. So now we need to figure out, how is the RV functioning? And again, we don't want to use qualitative measures of, oh, it looks like it's intact. We need to be providing multiple measures, especially when the RV morphology is abnormal. So everyone's really familiar with M-mode TAPSE. So you acquire this by placing the cursor along the lateral tricuspid annulus and measuring the amount of longitudinal motion of the annulus towards the apex at peak systole. Again, this is from your RV focus view. And essentially, this is a longitudinal measure of function, where the greater the base is moving towards the apex, the better the RV function is. There's a lot of caveats to TAPSE, especially in patients who are post-operative. It's not the end all be all. Oh, my TAPSE is normal. That must mean that my RV function is normal. Because again, I've shown you the base is really the last part of the RV to become impaired. So this is just one of the markers. It measures how far is the annulus moving towards the apex. That's it. Now, tissue Doppler S prime, again, the tissue Doppler cursor is placed along that lateral tricuspid annulus, and you're assessing the peak systolic velocity. This is how fast is that one segment of the RV moving towards the apex. It can be underestimated if your annular velocity, if the interrogation is not completely parallel to the plane of motion. So again, if your RV function is really desynchronous, this may be, artificially low. So again, it's just one of the measures of one single point of the RV, which is the base. So what I usually do, if things are discordant and they don't make sense, so the TAPSE is really abnormal, but the tissue Doppler is normal, and it's a patient whose RV is dilated, I will do a fractional area change. And what that is it correlates really well with RV EFI CMR. You're tracing the endocardial borders from that dedicated RV focus view and end diastole and end systole, making sure that you can see the entire RV free wall, and you're avoiding, going into the different trabeculations while you're tracing the area. Of course, if you get a beautiful 2D image of the RV and you have the technology on site, you can also do a 3D nicely from this view. And even better measures to look at RV free wall strain. So this is a mathematically derived software that's basically tracking how each of those ultrasound speckles are moving through time. So how speckle tracking works is that the ultrasound beam hits the myocardium, and through random reflection, refraction, and scattering of the ultrasound beam, you get speckles or pixels. And so that software is tracking each single pixel to summate here to generate these curves, and you can get both regional and an average of the regional components to get global free wall strain. Now, when we report strain, if you include the septum, that's not really RV strain, right? So that's also including the interaction between the RV and the LV. So if the LV is hyperdynamic and your septum is hyperdynamic, it may overestimate what your RV strain is. So you have to clarify, are you reporting out free wall strain, or are you reporting global strain, including all 6 segments? And then we can also use our pulse wave Doppler across the RVOT to calculate stroke volume. Just a few moments on 3D echo. So again, this is from an RV focused apical 4-chamber view. And you're stitching together, the software is stitching together sub volumes that are generated from 4 to 6 consecutive beats. If the RV focus view is suboptimal, sometimes you can use a subcostal view. You avoid stitching artifact by having the patient do a breath hold, or even placing a brief pause on the ventilator if the patient's on a ventilator. You want to make sure that you can see the entire RV free wall and apex. If the patient is in an arrhythmia, you can use a 2-beat volume acquisition, but again, that will reduce temporal resolution. And so the last part of RV assessment that we're going to talk about is now the hemodynamic assessment. And we can actually do a non-invasive SWAN by looking at echo. So in order to calculate your RVSP, you're going to take your peak TR velocity squared, multiply by 4, and then add your right atrial pressure. And if there is no RVOT obstruction or pulmonic stenosis, your RVSP and your PASP are the same. And so in this example, this is going to be 3.9 squared times 4, which is 58 plus whatever the right atrial pressure is. And notice here that the Doppler signal is dense and it's parabolic. So the relationship with what we would find invasively is probably pretty good. You can also calculate your PA end diastolic pressure. So here you're going to take the end diastolic PR velocity squared times 4. So in this example, it is 2.54 squared times 4 plus whatever your right atrial pressure is. And this is a good correlate of your PA diastolic pressure and an indirect correlate of your wedge pressure or your LV EDP. We also provided in the guidelines a lot of different calculations for mean PA pressure, although by convention, we're typically reporting PASP or RVSP. And then you can also calculate pulmonary vascular resistance by echo. You take your peak TR velocity, you divide it by the VTI across the RVOT times a factor of 10 plus 0.16. Now, one of the most common questions that we get in practice is, what are some of the best ways that we can measure TR velocity? Ken, do you have any tips for this?
For TR velocity, it's important that you use multiple views, first and foremost. I know a lot of us tend to think, just the apical 4 view is going to be our best view for that, but I would caution that people use their parasternal RV focus view. I would also use the parasternal short axis view. I find it best for me to line up for TR. I go to the apical 4 view, but I turn my transducer counterclockwise to either I have the RV focus view there, or I turn it all the way counterclockwise to where I flip to where the ventricle is on the right side. And then it kind of lines it up to where it's a better, you get a better Doppler signal. Also subcostal views, I would use those. Make sure you optimize your gains and your compressions to get the best Doppler signal as well.
Yeah, and in some cases, you can also use ultrasound enhancing agents or agitated saline. But again, I wouldn't measure, it's called the chin and the beard effect. So you really want to make sure that you're measuring the chin and not all of the fluffy artifact that may occur beyond that, because that can obviously overestimate your pulmonary arterial pressure. So you don't also want to overmeasure. It really depends on that CW Doppler contour. And then the last part of assessing hemodynamics non-invasively, of course, is to look at the right atrial pressures. We use the cutoff of 2.1, and then we're looking for normal respirophasic changes in the IVC diameter. We're using cutoffs of 3 for normal, elevated is 15, and indeterminate, we use a value of 8. And Ken, do you have any tips on how to measure the right atrial pressures?
Yeah, so what we generally do here is we actually go through we look at the IVC in the fullest position. We measure that. We also have them sniff when we do it, but we grab it when it's collapsed. So we measure when it's elevated, when you have it along without collapse and with collapse, we measure it for the variation between that, so you can tell whether it's collapsed 50% or not. We also do the hepatic vein here too, to see if there's any reversal. You'll see that reversal along in systole. And I would say make sure that if your patient's not able to do the sniff exercise, I generally put my beats out at 7 beats per minute to make sure that I can capture the respirations. M mode is a friend of yours to use with this too. And that's basically all I have.
Yeah, I'm sorry these videos aren't playing, but typically to obtain this, you're going to be subcostal with a marker at around 12 o'clock, and then you slowly kind of rotate the probe counterclockwise until you bring the IVC into view, and you should see it emptying into the right atrium. And we also provided an algorithm for how to determine right atrial pressures and some of the other secondary signs that you can see in patients who might be on the ventilator, who you're concerned about that might have elevated filling pressures. So we've touched on most of these. These are some of the important considerations in pulmonary hypertension, is that you want to make sure that you're adjusting your linear measures based off of whether or not the RV apex is displaced. You want to look at your eccentricity index. If there are discordant findings or if there's apical traction, make sure that you're measuring out a fractional area change, or at least providing a dedicated RV focus view for the physicians to do this offline. And then an acceleration time may also be helpful. So, in most of our standardized practice, we're obtaining a pulse wave Doppler across the RVOT, and you can actually look at the contour of that PW signal, and that gives you a lot of information. So here's a normal pulse wave Doppler, and see how it's kind of parabolic in shape. So again, as I mentioned before, the pulmonary vascular bed is really compliant and it's low resistance. But as the PA pressures begin to elevate, you can see that the Doppler signal has begun to change. The peak velocity starts to happen in early to mid systole. It starts to have this triangular shape. You may see mid-systolic notching from elevated pulmonary vascular impedance. And so there's almost backflow. This is almost like a restrictive filling pattern, like what we see with the mitral inflow. And then there's flow reversal in late stages. So I talked about this a little bit, which is how the RV is adapting to that increase in afterload is a phenomenon that's known as RV to PA coupling. So how does the RV contract against that increased afterload? And many people are now using TAPSE, PAPSE to measure that. And so what that is you're taking the tricuspid annular plane systolic excursion derived from M mode, and you're putting it over your PASP, so RVSP plus your RA pressure. Why this is important is that it's actually in the guidelines, and a normal value is 0.55. I have to say that clinically, we're not really doing this in our reporting structure. It is in the guidelines. Some of the PH people may want the different components of this for their own calculations offline. And so I at least provide that when I'm reporting out my echoes on patients with PH. There's been a couple studies, though, that have shown that TAPSE may not be the best numerator in that equation. So, I mentioned that there's a lot of inherent issues with TAPSE. It's actually will decrease during early phases of RV remodeling, but then it stabilizes before it drops again. Tissue Doppler is not really better. Fractional area change and strain over PAPC actually are a lot better than TAPC-PAPC, especially in patients that have structurally abnormal hearts. And this all correlates quite well with invasive measures. So I just want to kind of shift our focus a little bit to some of the key points that we hope to hammer into everyone during today's session. So key point number one, I hope that we've shown this to you, is that comprehensive standardized imaging is essential. And when you're screening patients, it incorporates structure, function, and hemodynamics. And when you're reporting, all of these things need to be incorporated to tell a story. In the updated guidelines, we presented recommendations for screening for PH and what are core elements of an echocardiogram, as well as what do we do in a patient who has PH, what is needed for the physician to prognosticate and even maybe escalate therapy. So echo is really central to PH care. Our pulmonologists and cardiologists are reading these reports with a lot of enthusiasm. And so we can't just be reporting on TAPC and saying that the RV is normal. It has to integrate. What does the chamber look like? How is it functioning across multiple measures? And it's really essential also to use some of the echo features to help us classify. We talked about those 5 different classes of PH. Trends over time are more important than any single measure. That's the other key point that everyone should remember. It's not just what TAPC was on that one echo. It's how does TAPC fit into the rest of the story. Now, when we look at echo, there are actually some core features that may help us bin these patients into the different pH classes. So group 1, again, pulmonary arterial hypertension, typically the left heart is normal and the RV is abnormal. These are younger patients that don't have cardiovascular comorbidities. This is an example of a patient with a massive RA, dilated and hypertrophied RV, abnormal eccentricity index, the pulmonary artery is enlarged, the IVC is plethoric, and there's also hepatic vein dilation as well. Group 2 I mentioned was post-capillary or left-sided heart disease. These patients have left-sided heart dysfunction. So either LV hypertrophy and or chamber dilation, reduced or preserved LV ejection fraction, pathologic mitral E over E prime ratio. Usually these are older patients that have cardiovascular comorbidities. They typically have aorta or mitral valve disease, and the right heart stays normal until late in the disease course. Group 3 is pulmonary hypertension due to chronic lung disease. Interestingly enough, these patients will typically have a normal or a small hypertrophied RV until late in the disease course. The acoustic windows are tough. These patients may be smokers, they may be obese, and there's varying degrees of left-sided heart disease like LVH or LA enlargement because there's a lot of shared risk factors that impact the entire heart. Difficult acoustic windows, so you can optimize this through using subcostal planes. Group 4 is, again, pulmonary hypertension due to chronic thromboembolic disease. These patients kind of mimic what group 1 looks like. So the RV will be dilated. Typically, your TAPC actually will reduce early in the disease course and stays low throughout, even after pulmonary endarterectomy. So the exact mechanisms of how these things happen, it varies, and that's why we have to use a systematic approach each and every time. Different disease states may also adapt their RVs in a different way. What's most important for everyone to remember is that RV dysfunction confers a very, very poor prognosis in pulmonary hypertension. Having an abnormal fractional area change or an RV free wall strain increases your mortality risk, no matter what your age is, no matter what your sex is, no matter what type of PH you have, or the PH disease duration. We also have shown that echo parameters improve how risk scores work in pulmonary arterial hypertension. This has become so important that the European pH guidelines have now included echo features in how they prognosticate pulmonary hypertension patients. There are core features, but the high risk ones that I want everyone to remember. If your right atrial area is greater than 26, if you have an abnormal TAPSE-PAPSE ratio, so low TAPSE and high PASP, and a moderate pericardial effusion, you have a 20% 1-year mortality. So again, echo is at the forefront of how we are prognosticating these patients. So we have to obtain the right images and we have to be reporting on them. But as I mentioned before, trends over time are more relevant than any single measure. We at Hopkins perform echoes annually in PH patients, but if you're titrating therapies, it may be more often than that. Key point number 3 is that in patients who you're not sure why they're short of breath, you can actually exercise them. So we have an exercise protocol, happy to share it with anyone who's interested, but we've shown in a couple of different studies now is that when you exercise patients who are at risk for developing PH, you may be able to unmask what type of PH they have, or is this secondary to diastolic dysfunction or valvular heart disease. So some of the key parameters that have been mentioned in the literature include measuring your mean pulmonary arterial pressure over cardiac output slope. That's really complicated to measure when you're actively exercising a patient. So what we do is we just look for a rest stress difference in your RVSP of greater than or equal to 20, or crossing an RVSP threshold of 50. And then you're looking at your rest stress changes in your E over E prime. So here's an example of a patient who came in with shortness of breath, but they had scleroderma, so we were really worried about them. Their resting RVSP was 21 when you added in the right atrial pressure. And then at 100 watts, they went to an RVSP of 50 and their E over E prime was normal. So we were very concerned that this is someone with scleroderma that has pre-capillary PH. And indeed, they went to the cath lab and were started on PH-directed therapies. Now, this is another example of a patient that came in with shortness of breath. The inflow pattern is impaired relaxation with indeterminate E over E prime. At 25 watts, they developed the pseudonormalization of their inflow pattern, as well as a pathologic E over E prime of greater than 14. There's a lot of papers on this about how to look at mean pulmonary arterial pressure over cardiac output slope. Again, I find that to be not very user-friendly in a clinical setting. It's great for research, but when you're looking at a patient who's exercising in real time, you really need to focus on some key core measures that you can get to kind of distinguish. And so what we do is we get an RVSP at every stage. We get a couple measures of RV function as well as a dedicated RV focus view so we can do fractional area change offline, and then we're getting diastology. And that is the PH protocol that we typically follow. So I'll conclude so we have a few minutes for questions. That I hope that, in the last hour, we have really showed you that echometrics of right heart chamber size and function are so important for screening, classifying, prognosticating, guiding risk stratification, and monitoring treatment response of patients with PH. You still do need a right heart cath, but there are characteristic echo findings that may help you classify whether or not a patient has PH, as well as what subtype of PH they may have. We'll emphasize again that serial measurements and an integrated approach that incorporates structure, function, and hemodynamics are more clinically relevant than any one single measure. And with that, we will end and open it up for questions.
All right. Thank you, Dr. Mukherjee, for that comprehensive review of such a useful guideline. And Ken, Mr. Ridley, for your excellent imaging tips. I'm going to start the Q&A session with one of the most common questions that was popping up in the from our attendees. In the setting of severe or torrential TR, when you're just thinking that that jet is not optimal, what is the most accurate way to calculate RV systolic pressure and evaluate for pH?
So with torrential tricuspid regurgitation, it's hard because a jet is eccentric. And so again, I would just have you look at the Doppler signal. If the Doppler signal is dense and parabolic, and it's elevated, it's probably somewhat reliable. But if you're really getting an underestimated, or it's like very chaotic and you're measuring again the beard elements instead of the chin and you're measuring the artifact, that's probably not as reliable. So really look at your Doppler signal, your CW Doppler, rather than just the color. And again, multiple views.
I really like that beard and chin. It really paints that picture. And you touched upon use of ultrasound enhancing agents, and when you talked about the beard and chin thing first, but is use of ultrasound enhancing agent useful to help obtain any of the 2D RV measurements, or are there any measurements that could also be overestimated or underestimated when you use ultrasound enhancing agents?
I think ultrasound enhancing agents are great for chamber size and function, and visualizing the RV endocardium. I don't necessarily recommend that for TR assessment, in every single patient. You can sometimes, especially if you're doing an agitated saline study, is you do the agitated saline and then you quickly go to, your RV focus view or your reversed four chamber, and you can get a really nice TR signal that way. We do that a lot during our TEEs. We'll administer agitated saline and then we quickly go to 120 and try to get the tricuspid regurgitation using that for enhancement. But again, it depends on your Doppler signal. If your Doppler signal is really chaotic and it's not dense, it's not going to be reliable no matter what agent you use.
That's really useful. Ken, I'm gonna punt this question your way. What imaging tips do you have for assessment of patients that are in intensive care unit? You can't adequately position them to obtain all of the views required. So if you have a very difficult parasternal short axis window, or you're unable to obtain the RV focus view, what are your suggestions for all of our sonographers who desperately want to do the right thing?
My suggestion would be, I'm glad you brought up this question, because if you don't have good parasternal windows or good apical windows, if you have a good subcostal window, that is your friend. You can duplicate it parasternal short at the level of the LV. You can duplicate a parasternal short at the level of the aorta. You can also, with the four-chamber view, assess it. So you have two ways to assess TR Doppler already. And then you get your IVC. I love the parasternal. I love the subcostal view, because you can almost do a full study off of the subcostal view. So I would recommend that people go to that. I would also recommend that people try doing off-axis views. I tend to think that works for me. I go to my view between the parasternal and the apical view, and I'm able to bring in a view to where I can see both the RV and the LV really well. So I would recommend you do that. I always tell people, don't be afraid to move. So always search, because you'll be shocked sometimes what you do find. So.
Gotcha. That is very useful. And I guess this is maybe for both of you. For accuracy's sake, which RV measurements should be performed in the RV focused view versus the true apical four chamber? And also I would add RA. We have actually had a lot of questions about that. Should you be measuring the RA in the RV focused view or in the true apical four chamber view?
Yeah, it's a great question. So typically what we recommend is that you get your RV focus view for and then you kind of tilt upward. So it's an RA focus view. And I would recommend that because there's frequently underestimation of the RA size if you use the apical four chamber alone. And we see that with the LA too. You really need to focus on the entire roof of the LA to adequately assess it. So a lot of times what I see is that people foreshorten the LA from that apical 2 chamber, and we're using a biplane measure. So if one of those measures is underestimated, you might be missing LA enlargement, and the same holds true for the right atrium. And in terms of the longitudinal measures, I don't think, it matters as much from an RV focus view versus an apical 4, as long as the entire RV free wall is in plane and your ultrasound beam is parallel to the angle of motion. That's actually more important than, using one view over another. Ken, don't you agree?
I do agree. I think as long as you make sure that you have that RV focus where it's at the apex, I think you get and I think you can get an accurate measurement there. And I encourage people to, like Dr. Mukherjee was talking about the TAPSE in the tissue Doppler from a certain view. I would encourage people also to do the volumes there, because it's helpful in a sense of like TAPSE's not always accurate if you do have RV failure and it starts at mid first, or if you have a patient with McConnell's or anything else, these are all things that we need to take into consideration to where we do those volume measurements.
Gotcha. And I'm going to end on one last question before I tell everyone how to get their CME. This question is a frequently asked question by facilities who want to know from us, what do we require with IAC standards, but not even really a standard type question. Is it better to measure TAPSE vertical line like this or slope, peak to slope? Which is better, or which is correct?
So both are correct. Some of the softwares you actually can't follow the slope exactly. You can only actually go up and down, and it doesn't really matter which way you do it, as long as you're really trying to maintain accuracy of that distance. So I would say that both are good as long as they're right.
Right. Great answer. Thank you for taking that tough question on.
Yeah, and M mode may help you. So
Yeah.
M mode sometimes brings out the peak of that signal a little bit more. So especially when like the RV free wall might not be well visualized, you can sometimes see if M mode plus color Doppler helps you. Ken, do you have any other thoughts on?
So usually when I don't see it that well too, I do like if I'm doing in mode and it's not inaccurate, I feel like it's inaccurate or I'm not visualizing well enough, I'll try tissue Doppler too to see if I can duplicate it.
Interesting. All right, everyone. Thank you again. Excellent presentation. So useful. And thank you for everyone who has attended. Please feel free to contact IAC with your questions. To receive your continuing education credit for attending this webinar, please complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from your IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Echo Evaluation of the Right Heart in Pulmonary Hypertension, Updates from the 2025 ASE Guidelines. Beneath this title, you will click Review Event, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through your CE transcript section on the My Account page. Please note that this certificate will not be emailed to you. If you have any questions about the survey, please contact us at webinars@intersocietal.org. And once again, we thank you for joining us today and appreciate your participation. Have a great one, everyone.